All right, I've completely given up on virtual classrooms, so this will be on YouTube. So welcome, it's Endocrinology. It is week 5. It is the winter of 2021. It is Tuesday, and today we're going to talk about adrenal insufficiency. We've really talked about adrenal insufficiency, but we haven't talked about the adrenal crisis, the dangerous adrenal crisis, and that's what we're going to talk about today. Where have we been? Last time we did talk about primary adrenal insufficiency versus secondary adrenal insufficiency. The bottom line of both adrenal insufficiencies is there is no cortisol, or not enough cortisol is released from the adrenal gland for various reasons, and there's 2 reasons. So you can have primary adrenal insufficiency, which is Addison's disease, is the strong AKA. And that's what they will use on boards, I'm convinced. Because why would they say primary adrenal insufficiency? And that tells you the exact problem. So Addison's disease. Remember, there's 2 causes in the Western world. It's usually caused by an autoimmune attack against 21-hydroxylase. We've talked a lot about that. And that enzyme is used to make both aldosterone and cortisol. And then in the world, especially in third world countries, tuberculosis, infection, is the #1 cause of Addison's disease. And that one will take out all 3 zonulas. So you'll have no aldosterone, no cortisol, and no adrenal androgens. Namely, we just call it DHEA, but the question could say adrenal androgens or any of those. But so what about ACTH levels? So these are the key kind of lab findings or blood serum findings. There'll be huge increases of ACTH because there's no cortisol to shut off the machinery that makes ACTH, and therefore you'll get over 90% of these affected will get a bronzing, blotchy bronzing of the skin, or brown spots all over the skin. Some people more of a tan look, but it's usually blotchy. You'll also have increased serum levels of renin because both of these adrenal insufficiencies cause hypotension, a dangerous drop in blood pressure. And in this case, because no aldosterone is being made, the R2A system, the angiotensin renin aldosterone system, is also trying to fix that hypotension by releasing renin, which I won't go into that again, but ultimately renin leads to the little Tasmanian devil, angiotensin 2, right? And that stimulates the release of aldosterone and a whole bunch of other things. So renin levels will be high. Aldosterone levels will be gone because this disease, both 21-hydroxylase and infection, will take out the zona glomerulosa, so no aldosterone. DHEA levels, that depends upon which type you have. So if it's an infection, tuberculosis will take out the entire adrenal cortex, then you'll also have decreased levels of the adrenal androgens, or DHEA. But if it's the autoimmune type, it tends to spare the zona reticularis, where DHEA is made, right? Because we don't need the enzyme 21-hydroxylase to take that one to make DHEA. So primary or secondary adrenal insufficiency, as a recap. So this is a problem in the HP axis. What does that mean, HP axis? That means the hypothalamus and or the pituitary. Usually a pituitary tumor that takes out corticotroph cells so they can't secrete ACTH. And remember, technically ACTH comes after the prohormone POMC. So technically corticotroph cells secrete POMC, and then the enzyme PC1 converts POMC into ACTH. All right, you'll have decreased levels of ACTH because it's not being made. So you'll also, of course, have decreased levels of cortisol. I didn't put that in there, but that's obvious. You'll have normal levels of renin. Why will you have near normal levels, I should say, of renin? Well, because ACTH has nothing to do with stimulating the release of aldosterone in the zona glomerulosa, right? That's angiotensin II's job. So that will be working. Now, it won't be working quite full power, because maybe 90-95% full power. But remember, ACTH does affect a little bit of aldosterone release. So you'll have a slight decrease, but it's really not clinically important. What about the zona reticularis? The adrenal androgens will also be decreased because ACH, remember who that stimulates? It stimulates the release, ACTH stimulates the release of cortisol, and it stimulates the release of DHEA. So those will both be decreased. All right. So how do you make the diagnosis? How do you know someone has adrenal insufficiency? And it's even in the emergency room, it can be very challenging because the symptoms are very flu-like and very vague at first. And that's true for both primary and secondary adrenal insufficiency. Once the hyperpigmentation, once the skin starts getting blotchy and affected, then we know it's Addison's disease, which is the worst of the two, right? If you could pick one, you probably would want secondary adrenal insufficiency. Addison's is no good, but that gives it away. But before that occurs, I mean, that can take a while to pop up. It's hard to say. And clinical findings in general. So they're very slow. It's usually a slow, insidious onset unless you've had, or until you've had, a major stressor. And probably the most common is some type of major infection from a gastrointestinal enteritis from a bug, or some staph infection or something like that is usually what sets it off. Because infection and stress on the body soaks up blood water. So it soaks up water out of the blood, it dehydrates you, and it soaks up sugar, it soaks up glucose as well. And so normally the adrenal gland would would fix that problem by cranking out aldosterone to fix the water problem, and cortisol mainly to fix the sugar problem. But cortisol is important for the water, for the hypotension as well, as we will see. I don't think I've taught you that before, but I will here in a second. So a major stressor occurs and the patient goes down, or they start talking crazy. They lose their ability to think. They get confused and they go to the hospital. And that's called an Addisonian crisis once the diagnosis is made of hypercortisolism, with not enough cortisol around. And yeah, it is a medical emergency. You can die from this. Even in the hospital, you can die from this. So this is, people get confused, they should be taken. It could be a stroke. I mean, there's a lot of things that could cause confusion. So Addisonian crisis, a very strong AKA is adrenal crisis. So they use these interchangeably, or acute adrenal insufficiency. That's not a great one. Doesn't really show you that there's a crisis. This is a life and death situation, so it is a crisis. It is considered an endocrinologic emergency. You need to go to the ER. You're probably going to die from this. Carries a very high mortality rate for those who are not treated. So what is it in general? If I could use 4 sentences to describe an Addisonian crisis. It's a life-threatening drop in blood pressure that causes hypovolemic shock, which we talked about last lecture or the lecture before in endocrinology. Hypovolemic shock means you don't have enough oxygen getting to the tissue, so globally your body tissue and your organs are not receiving enough oxygen, and you're getting ready to die if that's not fixed. Hypoglycemic shock can also occur, but it's usually seen in children. This is much more common, and adults tend to not get the hypoglycemic shock. I mean, either one of those shocks can kill you, though. So again, what's the cause? Well, it's a major stressor. We'll look at those major stressors like an infection. And normally, a major stressor occurs and it demands that the adrenal steroids are released, especially cortisol and especially aldosterone. Those are needed to fight off the effects of a major stressor. And again, those effects are it soaks up blood glucose and it soaks up blood water, and that's got to be replaced or you're in big trouble. Stress sucks up body fluids. It's not so much body fluids. I think if I can remember to change that, I'm going to put blood fluids, the future interstitial fluid. It's really blood fluids that it sucks up in glucose like crazy for a very general, in a very general sense. And great, so if you're low on blood fluids, there goes your blood pressure, right? You need to replace that with water, so you need aldosterone to suck salt and water into the body. You have ADH trying to fix it, but that's not enough by itself. And you need glucose if there's a low blood sugar component involved. You need that as well. But because we know in adrenal insufficiency you can't make cortisol in particular, you're in trouble. You can't fix the problem, and you're going to die unless you get an injection of cortisol. How does decreased cortisol and decreased aldosterone cause a hypovolemic shock? I kind of said so. But decreased aldosterone equals no absorption of salt and water from the kidney, from the filtrate of the kidney like normal. Therefore, you can't fix the hypovolemic problem because stress sucked all the water out of the blood and you have hypotension. Decreased cortisol, because in either one of these adrenal insufficiencies you can't make cortisol. Here's the one you don't know. This is new, I think, to my students. So I had to do some digging to figure out how does cortisol cause hypovolemic shock? So it turns out that cortisol sensitizes the norepinephrine receptors on the tunica media of arterioles and venules. Remember, we've talked about how norepinephrine is released in the tunica adventitia and it quickly diffuses into the tunica media. It stimulates the tunica media to contract, which narrows blood vessels. That's going on all the time. But for that to work normally, you have to have cortisol. Cortisol makes those receptors happy to accept the norepinephrine. Without cortisol, a lot of the norepinephrine bounces off the receptors and the tunica media just stays limp. And therefore you have a vasodilation, and then you have way too much. If that happens all over your body, there goes your pressure, right? If right now, if you pop all the blood vessels open all over your body, then too much blood will flow and your pressure will drop. You need those things constricted somewhat to keep the pressure and to keep the proper pressure going through the capillaries. So you'll flood your capillaries and you will lose some interstitial fluid as well through this response. But that's really important. I should have a lot more stars here, but this is new in this presentation. So if you're watching old videos, you won't see this. And you can bet I'm going to make a question on that. And then, also recall ACTH can drive a little bit of aldosterone release. So without ACTH, then you'll get you won't have full power aldosterone. So that affects the ability to pressurize the blood or pull water into the blood. Okay. How does decreased cortisol cause? This is easy. Hypoglycemic shock. Well, and we'll get to this in the next couple lectures. Cortisol is very important at making sure that you have enough blood glucose. And I'm talking between meals, because we can go eat or we can drink Gatorade or something, and we can put glucose in our blood that way. But what happens when you're fasting or when you're sleeping overnight and you run out of blood glucose and glycogen? Well, cortisol kicks on and it breaks down muscle, amongst other things, and fat. It breaks down fat and muscle. And it uses those breakdown products to make glucose through the process of gluconeogenesis, which we will look at. I get to put on my biochemistry professor hat in the next lecture or whenever it comes up, because I do like my gluconeogenesis pathways. So we will be heading that direction. But yeah, but if you can't make cortisol, how are you going to offset hypoglycemia? Well, you're not going to offset it. And you could go into especially kids, go into hypoglycemic shock, and you can die from that. So we keep talking about these major stressors. I said infection is the most common. Here are a list of the common stressors that can kick off adrenal crisis. So infection, bacteria, which is a infection that's actually gotten into the blood, septicemia or sepsis, which is very dangerous. That's bacteria have really built up in the blood. Severe trauma, especially when you're bleeding, because that will worsen the hypotension. Fracture a femur, fracture your humerus, fracture your spine. Major surgery, severe burns. Myocardial infarction is a major stress. GI illness is often from infection or inflammation, so that kind of GI illness kind of goes back that way. Severe physical stress, if you're Tour de France and you're racing and you're not used to that, that could set it off. Severe psychological stress is a little controversial. There wasn't a lot of research. There are some papers that show it can kick off an adrenal crisis, like death of a loved one or loss of a job or losing your home or some major thing like that, losing a child. Another concept, so it's not always a major stress in and of itself. Another common cause, in fact, some of the papers said that this is the most common cause for someone coming to the emergency room. They've been taking steroids for the last 3 months, and the doctor forgot to tell them, or maybe it was on the bottle and they didn't read it. Oh, by the way, you have to taper off this medication. They don't realize how extremely important it is to taper down the dose. Like if you're taking 40 milligrams for a month or 2 months or a year, then you got to go to 30 milligrams and then to 20 milligrams for 5 days and then 10 milligrams. You slowly taper off, because remember that glucocorticoids, taking glucocorticoid therapy shuts off your HPA axis. And it even atrophies it, so your hypothalamus, your parvocellular neurons, or your paraventricular nuclei gets thin. You don't use it, you lose it. Your corticotroph cells get thin and weak, and they stop working, and it takes a while for them to get turned back on, and sometimes they never get turned back on. So if you forget to taper and you just flat out stop taking your glucocorticoids, just the stress of a fast, just when you go to sleep overnight, you'll lose blood sugar, and there will be zero glucose to offset that, and you may not wake up from that. So very dangerous thing. You got to taper. Even if you're tapering, if you get hit with a major stress as you're tapering, that could kick off an Addisonian crisis as well. So it can be because of those vague symptoms, it's very difficult to diagnose at first. And you'll see here are these vague symptoms, and this is the Rathbun study, carefully studied the most common symptoms that patients presented with the ER with Addisonian crisis. They all had fatigue leading up to the crisis. They all had weakness. Tiredness is a very common complaint. Sometimes it's disabling, and they think the patient has depression and put them on depressive medications and send them to psychotherapy, and that's not even the problem. Achy joints. They're kind of flu-like symptoms, right? Anorexia, weight loss, 100% had those things. GI symptoms, vomiting, dyspepsia, diarrhea, probably from gastroenteritis, from an infection. So that's probably where that comes. Chest pain, back pain, less common symptoms. Maybe you have a bleed in the pituitary can cause these things. Dizziness, syncope, fever, back to the infection again. Increased thirst craving and salt craving. That's from the hypovolemia. We've talked about those. And then dehydration, part of the stress sucks water out of your bloodstream. And then polyuria. So that's pretty tough to diagnose. But once you see this, the game is over. Once you see the blotchiness is dark here and is light here. These are called palmar creases. If you see these palmar creases that look like somebody drew a pencil in here, a black pencil, and made them black, then you know it's Addison's disease. And this hyperpigmentation is seen in almost everybody. About 94% have this blotchy bronzing of the skin. And again, it's caused by very high rates of ACT. We'll actually have a couple slides on the end to talk about that a little bit more. And remember, this blotchy bronzing of the skin is absolutely not seen in secondary adrenal insufficiency. So that is a key. That's a, make a note card right now of that. You got to know that. You got to memorize that. Some of the dangerous symptoms as they get into the ER, they are out of it. They can't even give a history. Their significant other has to give the history because they're out of it. They're not mentally there. Maybe they're still haven't passed out, but there's a word for that called obtundation. Obtundation. That means they are really severe confusion and out of it. They will be in hypovolemic shock, really dizzy, white looking. Blood pressure will be low, below, way under 100 for systole. And they might be hypoglycemic, especially the children as well, so that could kind of a double whammy. How does secondary adrenal insufficiency cause hypovolemic shock? I think we said this already, but just to make sure, this is new slide. So cortisol, again, cortisol makes the norepinephrine receptors in the tunica media of arterioles and venules sensitive to norepinephrine, and we have to have sympathetic fiber doesn't directly plug into the tunica media of these important blood vessels which control blood pressure. It has to diffuse in from the tunica adventitia. Tunica adventitia is the outer layer of a blood vessel. Tunica media is the middle layer. Tunica intima is the inner layer that touches the blood, and we all hope you guys better know that by now or you're going to be in trouble, but in case somebody else is listening to this. So if you don't have cortisol, those norepinephrine receptors on tunica media muscle aren't going to be responsive, and therefore you're going to have vasodilation, and that's going to decrease the blood pressure and overpressurize the capillaries, so you'll lose fluid into the interstitium as well. And let's see, and then we said because secondary adrenal insufficiency there is no ACTH coming out. We said ACTH does help a little bit with the release of aldosterone, maybe 5% or so. So you will, without a 5% loss of aldosterone, that's going to contribute to the hypotension as well. Right? How do they present in the emergency room in an ER? Well, we kind of said some of those. Obtundation. So just a sidebar, history. I mean, because they're out of it, especially if they come in by themselves, well, then you're in trouble because they can't give a history. But if the parent there, or if it's a kid, or if it's the spouse, significant other, got to get a history. And there's three key findings. Number one, do they have adrenal insufficiency? Maybe they have a bracelet. I mean, these are the people who have to wear bracelets all the time in case they're in a car accident. Have they just been on glucocorticoid therapy for maybe a really bad bout of psoriasis, attack of psoriasis, and they've been on glucocorticoids for the last 3 months? So did they just stop it? Did they taper like they're supposed to? Well, what do you mean taper? I had a patient 2 weeks ago, and they came off a 10-day course, and nobody told them to taper. I'm like, are you crazy? You're supposed to taper. Physician didn't even tell me anything about it. And then they looked on the bottle. Oh yeah, it does say to taper, but nobody warned me about that. Anyway, and then here's another one. Do they have any concomitant autoimmune diseases? So does the patient have diabetes, type 1 diabetes, or do they have hypothyroidism, Hashimoto's disease? If you answer yes to any of these questions, you really suspect adrenal insufficiency is the cause of their the funk that they're in. So they present with super low blood pressure, hypotension. They have tachycardia and tachypnea. The heart and the lungs are going fast, trying to compensate for the loss of blood oxygen. They may have hypoglycemia, especially if they're a kid, on top of all of this. And they don't look good. They look white because they have a global decrease in perfusion. So their lips might be blue. They're just not getting enough oxygen. And then very commonly they're vomiting, they're nauseated, they have a fever, probably because infection is the number one cause of this, according to some authors. So that could be the cause of some of this vomiting and these abdominal symptoms. So what do you do next in the ER? Here's the lifesaver right here. That's hydrocortisone. So they'll get they'll already have an IV, right? Because they have hypotension, you got to replace fluids. So they're going to get 2 to 3 liters usually with 5% dextrose, depends. But normal saline, 2 to 3 liters normal saline for starters. But right into that IV, they inject 100 milligrams of hydrocortisol. They can use dexamethasone, but hydrocortisone is kind of the old standby from my understanding. And yeah, every 4 to 6 hours they give them another 100 milligrams until things comes down. This is their cortisol, and that's going to raise their blood pressure because they're missing cortisol and the other problems. Some people are critically ill. It doesn't raise the blood pressure enough, so they have to give them vasopressors. We won't worry about which ones, but like vasopressin actions it's going to stimulate principal cells to reabsorb free water. So basically it's a ADH agonist, so it's going to bind to these receptors and cause the uptake of free water. So, yep. So just a note that in the emergency room, sometimes this hypovolemia can be really, really tough to treat, and it doesn't respond to fluids and vasopressors like normally it would. So that's another clue that it could be adrenal insufficiency. What about the blood work in the ER? Well, they're going to have low levels of cortisol and or aldosterone. If it's primary, if it's Addison's disease, these will both be down, right? They'll have very high levels of CRH and ACTH if it's primary, or I guess we're talking about primary adrenal insufficiency. Yep, very high levels. Because there's no cortisol, there's nothing to shut down the machinery that makes CRH and ACTH. And then renin, they'll have super high levels of renin as well because their aldosterone is broken. And there's nothing to turn off the R2A system. It just trying to fix the hypotension, so it's cranking out tons of renin. And the angiotensin II will be, you could say there's high levels of that around as well. It'll be bouncing off. It'll be stimulating the zona glomerulosa or glomerulosa cells to try to make aldosterone, but to no avail because that system is broken. DHEA levels, again, from primary, it depends. If it is it depends a couple different ways. If it's secondary adrenal insufficiency, they're going to be down, period, right? Because secondary adrenal insufficiency means that there's no ACTH, and we need ACTH to stimulate the release of the adrenal androgens, or DHEA, if you will. What about primary is a little more different. I think we talked about this, but it depends. If it's from tuberculosis, which affects the entire adrenal cortex, including the reticular cells, then you're going to have decreased levels of DHEA. If it's not, if it's the type from an autoimmune attack, then you might have normal levels of DHEA because that usually spares the zona glomerulosa, and aldosterone is secreted about 90% of normal. All right, what about blood work? So if they don't have in primary adrenal insufficiency, so that means there's no cortisol and no aldosterone, so they'll have the effects of hyperaldosteronism, which we've talked about. Hyponatremia, about 88% have hyponatremia, low sodium in their blood, too much water. They have a water-rich blood. Hyperkalemia, too much calcium in their blood, or potassium in their blood, 64%. Metabolic acidosis is about 60% or so. And yeah, I don't have to talk, we've already went over that a lot. What about secondary adrenal insufficiency blood work? Well, again, that means there's no ACTH being made. So, well, of course they'll have, primary and secondary will have no cortisol. They will have low levels of DHEA or you could say the adrenal androgens or decreased androstenedione. They'll have a normal aldosteronism or near normal aldosterone levels because we don't need ACTH to stimulate the release of aldosterone. They'll have decreased ACTH big time because that's the problem. Secondary adrenal insufficiency, you can't release it. And maybe decreased levels of CRH. And it depends where the problem is in the secondary adrenal insufficiency. If there's a tumor in the hypothalamus, in the periventricular nuclei, that causes no CRH to be released, then you're going to have decreased CRH and ACTH. If the problem is in corticotroph cells in the anterior pituitary, your CRH levels might actually be high in that case because they're trying to stimulate corticotroph cells to release ACTH. The renin levels will also be normal here because, or near normal, because aldosterone is working or mostly working. 2 clues to the diagnosis. So, do they have concomitant autoimmune disease? We kind of said this already. Yeah, this is the important history questions that we asked. Are they just coming off glucocorticoid? Yeah, then they probably have adrenal crisis. Yeah, we kind of could probably pull that slide out of there. The blood work will detect increased ACTH. Kind of talked about this. Blood work will detect increased ACTH. This is in primary adrenal crisis, and increase renin levels. Yes, which helps make the diagnosis of Addison's disease. We've said all this before. In secondary adrenal insufficiency, there's a decreased ACTH, but normal levels of renin. So this is kind of a recap slide from everything we've talked about. So if you want to make the diagnosis for sure in the ER, you run a test, and the patient has to be stable, right? The blood pressure has to be controlled now. But you have to figure out, why in the heck did this happen? There's a famous test called the Acute ACTH stimulation test that can be run right in the emergency room. It's basically, they give you a shot of ACTH, and then they monitor your cortisol levels. And right after the shot of ACTH, if your cortisol levels kick up and you feel really good, then you know the problem is a lack of ACTH. So they probably have a pituitary tumor and they have secondary adrenal insufficiency. If they don't rise up at all, that's probably bad news. That's Addison's disease. Right. Now, there's another, the gold standard. Now, this has to be done. This can't be done in the ER, but it has to be done in the lab. There's this corticosine synactin test is considered the gold standard. It uses ACTH, but it's a much more controlled environment, and it's not like a kind of a flyby, just injection of ACTH. So I'm not going to get into it more than that. You can also look for 21 hydroxylase antibodies. Because remember, autoimmune attack of 21 hydroxylase is a common problem. So you can look for them. That might help as well. What about non-emergent treatment? What does that mean, non-emergent? A non-emergency room treatment. So after they leave the emergency room and Grandpa Joe now has the diagnosis of Addison's disease, what do they do now? Well, they're on medication for life. If they can't make cortisol and or aldosterone, you have to take replacements. So I do want you to know the name of these. So both of them, primary and secondary adrenal insufficiency, patients have to take hydrocortisone, period. And that's the cortisol replacement. Patients who aren't making aldosterone, which is going to be the primary adrenal insufficiency, the Addison's disease patients will have to take another medication called fludrocortisone. And yep, there they are right there. 20 milligrams a day usually of hydrocortisone does the trick. And that's that. But that's not that. because remember your adrenal gland releases these things. It releases real cortisol and real aldosterone, but your adrenal gland can sense stress and it can respond to stress accordingly. This can't. So you have to respond to stress or anticipated stress yourself by taking more of this medication. How much do you take? Well, the rule of thumb is if you have a minor stress, like you're going to go get a root canal, probably a little infection, inflammation for that, or you've got the flu, or you've had the injury, not a gigantic injury, you double the dose of your hydrocortisone. So you'll take 40 milligrams a day for the next few days. If you've had a major stress, like a major infection, a surgery, a major illness with fever, then it's 10 to 20 times the normal dose. And you can see how this is a lot between 40 and 200, 300, 400. These are intramuscular injections. You can't take enough pills for this. So these are usually intramuscular injections for this. And you can talk to people who, I think we said in the last lecture, it was about 20 to 30% of people who are on this type of therapy, about once a year, they mess up and they go into adrenal crisis because of this, because they messed up. They took too much, or took too little, or took too much. So it's significant morbidity if you have Addison's disease or secondary adrenal insufficiency. What about the DHEA insufficiency? A lot of the books don't talk much about it, and it's actually kind of controversial whether you need to replace it or not. Males, I think it's pretty much determined you don't need to give them any medication to replace the DHEA, because they can make testosterone in their testes, so it's not that big of a deal. But in females, it's a major producer of their androgens, and so females who have secondary adrenal insufficiency, or from an infection or for whatever, females who don't produce DHEA will have a profound androgen deficiency. And so what are the symptoms? So the number one complaint is a decreased sex drive. They have no interest in sex. Some research, I didn't put in here, but some research says that the orgasm is greatly affected as well. Their muscle mass, if they're athletes, they complain that they can't, their times are down and their lifts are down. They're not as strong as they used to be. Just testosterone complaints. They're depressed. They have low energy. Pubic hair thins, or they can lose their pubic hair and axillary hair. So these are some of the complaints. The problem is, back to the research, that some of the papers have tested, given placebos to see if giving replacement DHEA does anything, and some of it says it doesn't. The people with the placebos did just as good as the ones who had the real DHEA replacement. And so it's still controversial to this day whether or not. If I was a female, I probably would take it, because it sure makes sense that you need that type of testosterone. So I said I'd come back to skin hyperpigmentation. I think we've talked about this, but it's so important. Let's go through it again. Yep, that's seen in Addison's disease, where there's nothing wrong with the pituitary and there's no cortisol to shut off the production of ACTH. So POMC, ACTH get overproduced, and the excess ACTH gets into the dermis via the blood vessels, and it's converted by PC2, an enzyme, into alpha MSH, melanocyte stimulating hormone. And that stimulates the melanocytes to overproduce pigment. Melanocytes, of course, give every 24 days a new skin cell is born, and it has to be injected and filled with pigment. And the darker you are, the more pigment is injected by these melanocytes. About 94% of people with Addison's disease, they get a hyperpigmentation, because the melanocytes get overstimulated and go crazy, injecting way too much pigment, and it's a blotchy pigmentation. So there's a little melanocyte, Stratum basale, it's injecting these brand new keratinocytes with melanin. Remember, the melanin goes over the nuclear cap, protects against the evil. I just talked about this in dermatology, talked about malignant melanoma. It protects the nucleus where your chromosomes are from the damage of the sun. And the great irony is the committee forgot to protect the melanocytes. The melanocytes don't have melanin inside of them. All their melanin is in their tentacles, and it's all injected. So, but if you have too much ACTH, it can be converted to alpha MSH by PC2, the enzyme. And MSH drives these things crazy, and they over-inject, typically unevenly, so you get a really blotchy type pigmentation. And yeah, and remember again for the millionth time, secondary adrenal insufficiency doesn't do this because there's no ACTH. The pituitary is broken and doesn't make ACTH, so you won't see this in them. So again, it's a patchy pigmentation. It's commonly seen in areas where there's sun exposure, in the creases of your palms. I showed you a picture of that. Where you had a recent scar tissue tends to be more amenable to this effect. The nipples, the axilla, the knuckles, friction points, and the gums are particularly affected by this. Here's a patient before her corticosteroid therapy, or before she was diagnosed with Addison's disease. She was dark. She's normally light. I don't have a pre-picture of her. But a year after her hydrocortisone treatment, you can see the marked difference of her hands. The color's grossly changed. Here's another young lady who has Addison's disease. And you can see it's kind of blotchy, like her nose is darker than the cheeks. The chin is dark. So it's a blotchy pigmentation. Here's gums of someone with Addison's disease, and you can see the blotchy gums. That's not cancer or anything like that. And there's the palmar creasing again, where the hands are blotchy. All right, so that was a lot to that. It's a tough lecture, so listen to it, think about it. It's really important stuff for you to know because you're going to run into these people out there in your career. See you later.